Hey guys, it's Medicosis Perfectionalis, where medicine makes perfect sense. Let's continue our 5-minute review playlist. And today, we will review Nephrotic Syndrome and Nephritic Syndrome. Is my kidney losing lots of protein in the urine, or is my kidney bleeding into the urine? Is it proteinuria or hematuria? This video is going to go super fast. If you have any trouble understanding these concepts, please refer to the previous videos. Those are to be found in my 5-minute review playlist, as well as my nephrology playlist. To lose protein or blood, this is the question. If you're losing protein, nephrotic. If you're losing blood, nephritic.
But hey, Medicosis, that was kind of naive. Can we dig deeper?
Sure. Nephrotic syndrome has 4 clinical features. Nephritic has 7. Nephrotic, high protein in myuria, low protein in myemia, edema, and hyperlipidemia. Because of the low protein in myemia, I get decreased oncotic pressure, I get increased LDL cholesterol, I have increased risk of infections and thrombosis. How about nephritic? 7 features: hypertension, hematuria, jugular venous distension, oliguria, mild edema, and proteinuria, and intrarenal azotemia. We have just talked about the clinical features.
But how about the histopathological features?
Now let's talk about those. Nephrotic syndrome, minimal change disease, focal segmental, glomerulosclerosis, membranous, diabetic, amyloid nephropathy. We have 5 nephrotic, we have 4 nephritic, we have 2 doofuses in the middle. What are the 2 doofuses in the middle? Diffuse proliferative glomerulonephritis and membranoproliferative glomerulonephritis. Tell me about the 4 nephritic syndromes. Acute poststreptococcal glomerulonephritis. Some people call it post-infectious. Same thing. And then we have rapidly progressive glomerulonephritis, which is crescentic. Next, IgA nephropathy. Last, Alport syndrome. Let's talk about nephrotic syndrome. The high protein in myuria, low protein in myemia was responsible for a kidney loss of protein, a protein losing nephropathy, ending with decreased oncotic pressure, dependent pitting edema. The edema is spitting, dependent, made of transudate due to decreased oncotic pressure, and you'll find in the dependent area. If you're standing up and walking and kicking, it's gonna be in your ankles. If you're bedridden, it's gonna be in your sacral area. The edema caused by kidney disease is usually associated with periorbital puffiness, unlike the edema of cirrhotic and CHF. So what are the 3 most famous causes of generalized edema? Cirrhotic, nephrotic, and CHF. Cirrhotic, nephrotic, CHF.
Hey, Medicosis, how do I know that the patient has proteinuria?
The definition is protein in the urine greater than 100 milligrams per surface area per day. You have 2 methods: an easy, cheap method that's not very accurate, and a very bothersome method that is way more accurate. In neonates, infants, etc., it's very hard to collect 24-hour urine. That's why we gotta use something called total protein to creatinine ratio. So, you did the stupid urinalysis dipstick test. You found protein in the urine. This could be false or could be true.
How did you know that it was false?
I repeated the same stupid test. In the second time, it gave me a negative result. So it was positive on the first, it's negative on the second. I know this is fake. The first one was a false positive. Or it could be true proteinuria, but don't worry yet. Because if you are a surgeon or a police officer who stands up the whole day, you can get orthostatic proteinuria. That's not a kidney disease. Don't worry about this. In the evening, when you lay back down, everything is going to be hunky-dory. How to diagnose this? You take 2 tests. 1 in the morning, 1 in the evening. You will see the discrepancy.
But what if the police officer is working night shift?
Then it's going to be the opposite. Use your brain. Dadgummit. If there is no difference between morning versus evening proteinuria, this is called persistent proteinuria. I can blame your glomeruli or I can blame the tubules. Who decides? The beta-2 microglobulin. I have a separate video about this topic. Histopathological subtype of nephrotic syndrome. 1. Minimal change disease. The patient is young, the disease is mild, the prognosis is excellent because you give them steroids, they respond like magic. There is some association with Hodgkin's disease. The proteinuria is very selective. Not everything is lost in the urine. Only albumin is. By light microscopy, the glomeruli are normal or almost normal. Under electron microscopy, you'll see effaced podocyte foot processes. There is no immune complex deposition. Clinically speaking, sudden onset followed by sudden offset of selective proteinuria in a child is usually minimal change disease until proven otherwise. Next, focal segmental glomerulosclerosis. The patient is older, the disease is more severe, the prognosis is worse because there is poor response to steroids. Some of these patients have HIV, heroin addicts, parvo B19 infected patients, IgA nephropathy too. This, if it was secondary, but in many cases it's idiopathic, which means we are idiots and we cannot figure out the pathology. Proteinuria, of course, and maybe some microscopic hematuria that's not visible to the naked eye. The proteinuria is getting worse, aka non-selective. You are losing both albumin and protein in the urine. By light microscopy, focal segmental sclerosis and hyalinosis with lipid-laden foamy macrophages. Electron microscopy, same effacement. Careful, because this is not sudden onset, sudden offset of proteinuria. This is gradual progression of the disease. Unlike rapidly progressive glomerulonephritis, which is going to be rapid progression of the disease. Third, membranous nephropathy, the second most common nephrotic syndrome in adults. What's the number one? Let me know the answer in the comment section. The patient is usually older. I can get proteinuria and hematuria. I can get thromboses, big time. Light microscopy, diffuse thickening of the capillary wall. Electron microscopy, subepithelial immune complex deposition, giving me a thickened glomerular basement membrane with the classic spikes and domes to see them beautifully stained with silver. If you want them to shine, use immunofluorescence. This disease is usually associated with a certain type of antibodies. The proteinuria is non-selective. Could be primary, idiopathic, or secondary to syphilis, hepatitis B, hepatitis C, malaria, schistosomiasis, cancer, Hodgkin, etc. Please don't ever forget lupus. Membranous lupus. Lupus is also going to be involved with diffuse proliferative glomerulosclerosis and others. 4. Diabetic nephropathy. The patient is diabetic, no kidding, chronically for more than 10 years. Could be type 1 or type 2. Usually poorly controlled blood sugar. Hypertension is a risk factor on top of the diabetes. Gradual proteinuria. We start with microalbuminuria, and then it becomes macroalbuminuria, and then everything is getting lost in the urine, nephrotic range proteinuria. More than 4 grams of proteins are lost in the urine per day. Light microscopy, you have thickening, you have hyaline arterial sclerosis with the famous Kleinstein-Wilson nodule, diffuse mesangial sclerosis, papillary necrosis, podocyte fusion. Don't forget to manage the underlying disease, and these patients usually benefit from ACE inhibitors, big time. Remember, I told you before that ACE inhibitors work like magic in 3 diseases. 1. Diabetic nephropathy. 2. Scleroderma nephrosis. 3. Henoch-Schönlein purpura with the associated IgA nephropathy. 5th, amyloid nephropathy. The patient has amyloidosis, could be primary or secondary. Primary, multiple myeloma, cancer. Secondary, any chronic inflammation can do it. The most commonly involved organ in amyloidosis is your poor kidney. How do I diagnose it? Diagnose the underlying condition and use apple green birefringence or Congo red stain to see amyloid deposits in the arteries, arterioles of the kidney, glomerular tuft, capillary walls, mesangium, and the interstitium of the kidney. Many of these patients will end up with chronic kidney disease. The prognosis depends on the underlying condition and the extent of the amyloidosis. You can never treat amyloid nephropathy until you manage the underlying disease. If the patient has Crohn's disease, manage the Crohn's first. And that was nephrotic syndrome. Pause and review. And oh, by the way, if you would like to download these slides right here in PDF files, go to medicosisperfectionalis.com. Next, Nephritic Syndrome. 7 clinical features, 4 histopathological subtypes. Why do you call it nephritic? It came from itis, which means inflammation. Your glomeruli are injured and they are bleeding into the urine, shedding tears of blood. Wow, that's an injury.
Hey medicosis, my patient's urine looks dark.
Step number 1, establish that this darkness is actually made of individual red blood cells.
How the flip do I do it, dipstick?
Shut up. Dipstick cannot tell the difference between myoglobin, hemoglobin, or freaking pigment, so therefore you need what? Microscopy. You have to look under the microscope and see and count the individual red blood cells. But urine dipstick is so stupid that I can have actual, true hematuria, but I eat too much vitamin C and I will end up with a false negative test result. The doctor will tell me,
hey son, you do not have nephritic syndrome. Just go home and enjoy life.
Shut up. So step number 1 is to establish that this is true hematuria caused by actual red blood cells in the urine. Step number 2, should I blame the kidneys? Should I blame the ureter? Should I blame the bladder? Should I blame the urethra? Where the flip is the blood coming from? Well, to understand where, look for dysmorphic red blood cells and red blood cell casts in the urine. If you find them, blame the kidneys. Step number 3.
Should I blame the glomeruli of the kidney or the tubules of the kidney?
To decipher between the two, order the beta-2 microglobulin test. If everything hits the fan and you cannot establish a diagnosis, go with a kidney biopsy. Now let's talk about the subtypes of nephritic syndrome, but before we do this, let's just talk about the 2 doofuses in the middle, nephrotic nephritic syndromes. The first doofus is diffuse proliferative glomerulonephritis. Nephrotic nephritic, the patient has lupus. It is the most common and the most severe subtype of lupus nephritis. Hypertension, hematuria, proteinuria, you name it. My glomeruli are inflamed, hyaline thrombi, capillary wire looping inside my kidney. Electron microscopy and immunofluorescence will show granular subendothelial immune complex deposition. That's the reason behind the wire looping. Lupus is an immunological condition, so treat with immunosuppressants. Unfortunately, many patients will end up with rapidly progressive glomerulonephritis, followed by chronic renal failure, followed by end-stage renal disease, and then dialysis or kidney transplant, or we're gonna miss you. Lupus is evil. The second doofus is membranoproliferative glomerulonephritis. We have 2 types of this, type 1 versus type 2. Type 1, subendothelial, but type 2 goes into the membrane. Tell me about type 1, subendothelial. Tram-track appearance because of the banana split. I split the glomerular basement membrane into 2 halves. Associations with hepatitis B, hepatitis C, cryoglobulinemia, nephrotic and nephritic of course, eventually chronic kidney disease. How about type 2? We have dense deposits that go into the glomerular basement membrane. It's type 2. We go into, but then the mnemonic has to do with 3s. 3Ds, dense deposit disease. C3 nephritic factor, consumption of my C3 complement protein, and hypocomplementemia. Also chronic kidney disease and banana split. The management is very similar to diffuse proliferative. Pay attention, this is a very important clinical pearl. A kid came to you. Alright, if you listen carefully, the patient will diagnose himself. Parents will tell you, doctor, there was upper respiratory tract infection, pharyngitis, laryngitis, etc. And then, after a while, there was blood in the urine. Your question should be, what do you mean by after a while? How long? If they said, well, actually, I think they happened at the same time. There was pharyngitis and there was blood in the urine. There was blood in the cough and blood in the urine. This is IgA nephropathy. But if the parents say to you, doctor, the upper respiratory tract infection happened first, and then 2 to 3 weeks later, I saw blood in the urine. This is acute poststreptococcal glomerulonephritis. Take good history from the patient, you freaking doofus. acute poststreptococcal glomerulonephritis, the most common post-infectious glomerulonephritis, especially in children. Nephritic syndrome, of course. I started with streptococcal pharyngitis or streptococcal skin infection, followed by blood in the urine. Hypertension, hematuria, fever, proteinuria, periorbital swelling, or maybe even generalized edema. Diagnosis, history, symptoms, positive anti-DNase antibody, and maybe, or maybe not, positive anti-ASO, anti-streptolysin O. If it started pharyngitis before the kidney disease, usually ASO will be positive, but if it started as skin disease, usually it's going to be negative because cholesterol in the skin has been exposed, and this will dissolve the ASO, something your woke professor will never tell you. It's a diffuse involvement of the kidney with neutrophilic proliferation, subepithelial immune complex deposition, Streptococcal is subepithelial, and you treat with penicillin and supportive care. Complications are rare in children, more common in adults.
Hey, medicosis, what if my patient is allergic to penicillin?
Give erythromycin. Next, the evil, rapidly progressive glomerulonephritis, from blood in the urine to complete kidney failure in a matter of days. That's evil. Crescentic action here because of the proliferation of the parietal layer of the epithelium. Hypertension, hematuria, severe intrarenal azotemia with poor prognosis. Classification is based upon the presence or the absence of immune complexes. If they are present, are they linear or granular?
They are linear, medicosis, just like that.
It's Goodpasture syndrome.
No, medicosis, it's actually
Granular. Stop and think. If the patient has lupus and the granular immune complexes are subendothelial, this is diffuse proliferative glomerulonephritis. But if it's a kid with pharyngitis or scarlet fever and subepithelial, then it's post-streptococcal glomerulonephritis.
Hey, medicosis, I looked. There were no immune complexes.
This is pauci-immune. Pauci means few or none. And these are the nasty vasculitides. Granulomatosis with polyangiitis is C-ANCA. All the others are P-ANCA. Try to treat the underlying disease. Use immunosuppressants. If you find some nasty autoantibodies, try to plasma exchange or plasmapheresis to get rid of the nasty antibodies. Unfortunately, many patients will end up needing dialysis or kidney transplant. Goodpasture syndrome. Remember my mnemonic? Everything here was 2. It's associated with HLA-DR2, which is class 2 MHC. Male dominant, remember King Tut. He was a male. I have 2 problems and 2 symptoms. What are the 2 pathological problems? Antibodies against the basement membrane of my alveoli and antibodies against the basement membrane of my glomeruli, causing hemoptysis and hematuria respectively. 2 plus 2 equals 4. Type 4 collagen is under the floor, the basement membrane, and it's totally screwed up.
How do I manage Goodpasture?
4 methods. Number 1, get rid of the nasty antibodies by plasma exchange or plasmapheresis. Number 2, immunosuppressants. And then when everything hits the fan, you go with 3, dialysis or kidney transplant.
Next,
IgA nephropathy, Berger disease with E, not UE. If you see BUER, this is thromboangiitis obliterans, which is a totally different condition. Nephritic for sure, and this is a clinical triad of bleeding from my alveoli, bleeding from my glomeruli with synpharyngitis. At the same time this is happening, I also have pharyngitis, or at the very least 1 to 2 days later. It's the most common chronic glomerulonephritis in children. Hypertension, hematuria, fever, proteinuria. Serum IgA is high, probably because it's not being broken down. And when IgA is high in my blood, it's going to go everywhere, destroying my kidney, especially in the mesangium. There is a very important association between IgA nephropathy and henoch-Schönlein purpura. In fact, if you biopsy the purpura in these kids, you'll find, guess what? IgA antibodies in their skin. Since there is an immunological involvement, give immunosuppressants. and give ACE or ARBs. They can help. Complications are chronic kidney disease. Last, we have Alport syndrome, mutation of alpha chains of type 4 collagen. Type 4 is in the floor, it's in the basement membrane. Mostly X-linked recessive, which means mostly boys. Triad of Nephritic syndrome, sensorineural hearing loss, ocular findings, which include anterior lenticonus and bilateral congenital cataracts. You diagnose by the clinical picture by electron microscopy to see lamellated glomerular basement membrane because of longitudinal splitting of the lamina densa. That's the banana split once again. Complications, end-stage renal disease. Treatment, dialysis or kidney transplant. Here is nephritic syndrome. Pause and review. Let me review the immune complex deposits for you. Membranous was subepithelial, just like poststreptococcal glomerulonephritis. Diffuse proliferative was subendothelial. Type 1 membranoproliferative was also subendothelial. But type 2 is the dense deposit that goes into the membrane. And then Goodpasture syndrome, I have antibodies attacking the basement membrane of my glomeruli, usually no visible deposits. In IgA nephropathy, there is IgA antibodies in the mesangium. In Alport syndrome, you will not see any of these in the kidney. It's just a genetic disease. It's not related to immune complexes. So there you have it, the easiest, most robust review of renal pathology. This video doesn't hold a candle to my antibiotics course. 40 videos, baby, about antibacterials, antivirals, antifungals, antiparasitic medications. You can download it today at medicosisperfectionalis.com. No subscription needed. You download it once and keep it for you forever. I also have kidney physiology course, an acid-base course, neuropharmacology course, cardiac pharmacology course. I got all kinds of courses. Thank you for watching. Please subscribe, hit the bell, and click on the join button. You can support me here or here. Go to my website to download my courses. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine makes perfect sense.